Hi, we are going to talk about clotting with thrombocytopenia, ITP, and HIT as your exemplars. This is not a standalone category in your textbook. Thrombocytopenias were integrated throughout, so I have gathered data for you using several sources that I had, some MedSearch books and a critical care book for you. But you have all the information you need. So be sure and have your outlines ready so that you can take some notes as we go through our presentation here. So don't forget to look at the clotting concept analysis here, subcategories, positive, negative attributes, interrelated concepts, and fundamentally this is what you need to think. I have clotting. So I have an issue if I have too much clotting. I've got clots running around, which means I have poor perfusion. And I also have an issue if I don't have enough clotting, which means I'm bleeding, and I can have issues from that. So we're going to kind of span those too much and too little as we talk through these exemplars. Okay, so what I did was just start with some basic information on thrombocytopenia. So we're really looking at the platelet count. I abbreviate that PLT, so when you see that, that's just platelet count. A normal platelet count is 150,000 to 450,000. Sometimes we just kind of drop some of those zeros and say 150 to 450. Anything less than 150,000 is considered a low platelet count. Critical values are at 30,000, and spontaneous bleeding can occur at 10,000, which certainly is very, very low. So these problems with thrombocytopenia come in three forms: decreased production, increased destruction, and increased consumption. So I did make you a table that kind of lists some examples of those and management of those, because you know I like a good table. So decreased production is cancers like leukemias, anemia, aplastic anemia, your folate and B12 can lead to low platelet counts, infections, certainly chemotherapy, and anything that deals with your bone marrow, because that's our bone marrow is what produces our platelets. Increased destruction is really diseases and problems like lupus, ITP and HIT, which are the two that we're going to talk about, and sepsis. And increased consumption is from things like major bleeding. So as I'm bleeding, I am losing platelets, clotting factors because I'm trying to stop this bleeding. Massive blood transfusions, and that is actually because we are diluting the platelets because we're filling you full of fluids, so normal saline, and giving you RBC. So during blood transfusions, we do need to stop and at some point give you some platelets and give you some fresh frozen plasma, which has your clotting factors in it. And we'll talk more about that in class when we talk about blood transfusions. And then certainly things like severe embolisms, like pulmonary embolisms or thrombosis, that we just depleted our platelets because we've made such plugs. The other piece that I want you to think about that I got to thinking as I was putting this together is our medications. So it can be some antibiotics. The lists of my various subjects did not have the same drug list, which I found to be interesting. Antibiotics were listed. Sulfa was listed several times separately. Certainly NSAIDs, because we know they cause bleedings. And then you need to think about our anticoagulant and our antiplatelets that we are giving specifically for those reasons, but can have problems. And anytime you give an antiplatelet, that medication gets bound to the platelets. So that's our aspirin, our clopidogrel, and our ticagrelor. And then certainly anticoagulants like heparin and warfarin. And then we can't forget our apixaban, and then our other two new over-the-counter that I cannot think off the top of my head what their generic names are. That's Xarelto and Pradaxa. So don't forget about your medications. Okay, so let's talk about these clinical manifestations. basically, if their platelet count's greater than 150,000, we really won't have bleeding. We won't see petechiae. That just doesn't occur. And petechiae is just bleeding under the skin. If our platelets are less than 20,000, that's where we're going to have bleeding. We can have heavy periods. We can certainly bleed after surgery because we just don't have many platelets. And under 5,000, we do have spontaneous, life-threatening, like central nervous system, so bleeding in your brain or GI bleeding, and that is certainly life-threatening, and we would need to treat that. So in your notes, it does give some types of bleeding that you see with this platelet count at about 20,000. We're going to really talk more about that when we talk about ITP. If the function of the platelet is altered by medications or diseases, then bleeding can occur even within normal levels of platelets. So that is talking about those medications or any diseases that give us problems. So let's talk about the treatment. The treatment's pretty straightforward for this. We're going to manage that thrombocytopenia and treat any underlying disease. So you can kind of go back up to this table and see that if it's medications, we're going to stop the meds. If it's based in infection, then we're going to treat the infection. Chemotherapy, we can delay it or decrease the dose. We could give them a platelet transfusion. Chronic alcohol abuse, liver disease, treat those things, refrain from alcohol, that will help. H. pylori can cause decreased platelet production, so we need to test for that and treat that. And then we've already talked about, like with major bleeding, to give platelets and FFP. So platelet transfusions are used for impaired production causes because it will increase the platelet count and help stop bleeding and prevent spontaneous hemorrhage. It is not used for excessive platelet destruction causes because the platelets we transfuse will be destroyed, so it doesn't do us any good. And then worst case scenario, a splenectomy can be done. We can see some good outcomes from that, but we do need to think about what doing a splenectomy is going to do for them. And because your spleen is interrelated with immunity, they do need some vaccines, if at all possible, before that splenectomy, and those details are in your outline. Okay, so let's talk about our first exemplar, which is ITP. So immune thrombocytopenic purpura, or immune thrombocytopenia, or idiopathic thrombocytopenic purpura. It goes by all of those names. The immune is really the term that we see now. So there is a primary and a secondary. So primary occurs in isolation from an unknown cause, which is where the idiopathic came from, and it's pretty rare. What we do is see is secondary, which is most common and results from autoimmune diseases such as lupus, viral infections like Hep C, HIV, drugs, chemotherapy, NSAIDs, heparin, sulfa, penicillin, or just some of those meds that I grabbed. It is the most common cause of excessive platelet destruction. And what happens here is the immune system mistakenly attacks and destroys the patient's platelets. The bone marrow tries to compensate by increasing production, but it just can't keep up with all of these destroyed platelets. So I did give you a little JPEG in your notes that talk about the signs and symptoms so that you can see that, because I know that you all like those kinds of things. I just didn't get it on my PowerPoint. So let's talk about what these patients look like. Most of the time they are asymptomatic, and it may be an incidental finding that we find out that they're thrombocytopenic when we just do routine labs and realize that their platelet count is low. These platelets, despite the fact that their platelet count are low, the platelets are young and they are functional, and they do tend to adhere to the endothelial surfaces. Um, and so spontaneous bleeding really doesn't occur much with this. It can certainly at the lower levels. And treatment is not initiated unless bleeding becomes severe or life threatening. So, most of the time, they're asymptomatic, and we are just going to monitor them and help them adapt their life to this lower platelet count. So, they can have petechiae, which are small red bleeding under the skin. They can have purpura, which are bigger bleeding, and actually, little known fact to me, you have dry purpura and wet purpura. So in your notes, specifically that wet purpura, those people have the greatest risk of life-threatening bleeding, and aggressive treatment should be initiated. And that wet purpura is they have these blood-filled vesicles seen over their mucosa, their palate, their tonsils, their lips. So when you see that, these people are in trouble. And the dry ones tend to be the ones on their extremities. So they just have this minor bleeding under the extremity. So it's really not causing any problems, but think about it. If you have a bunch of those little purple spots all over you, people wonder what's wrong with you. They may look at you and think that you're contagious. You will have some ecchymosis or some bruising that's big, and it can be really large if you actually just bump into something or fall and hurt yourself. You can have a very large bruise or hematoma come up. They can have gingival bleeding, they can have nosebleeds, they can have heavy periods. If a sanitary pad is soaked, that's 50 mils of blood is all that is that can soak a pad. I did find that in one of the references and added that because I found that to be really interesting, because we do see lots of reasons why women have heavy periods, and certainly can lead to anemia and other problems. They can have vomit blood. They can have blood in their stool called melena. They can have hematuria. And then probably the worst place, GI bleeding is bad because you can bleed to death from bleeding in your GI tract, whether it's upper or lower, is central nervous system bleeding, which would be into your brain or brain stem. So, if they have a platelet count of less than 20,000 and a history of prior minor bleeding episodes and advanced age, that is predictive of more severe bleeding. Certainly, the wet purpura is more severe bleeding for them. The other things that we're going to look at is our lab test. I did make you a table that I stuck at the very end just before the nursing process questions about what lab works look like, looking at platelets, coag studies with ITP, HIT, and also I included D-dimer in that. So the lab studies, we're certainly going to get a CBC, and we're going to look at their platelet count. We can do coag studies, which is looking at PT, PTT, or APTT. The A stands for activated. It is more accurate for patients receiving heparin. We can do a fecal blood account. We can certainly do a urinalysis looking for hematuria. We might need to do a bone marrow aspiration or biopsy to see if that's the problem, especially related to things like leukemia, and screening for diseases like Hep C and HIV. So let's talk about our treatment. The goal is to have their platelet adequate to maintain hemostasis. We're really going to observe them if they're between 30 and 50,000. If they're over 50,000, we're probably really not going to do anything. Certainly, if a medication is causing this, we're going to stop that med. We can do platelet transfusions for the wet purpura or catastrophic bleeding. And then our two medications are corticosteroids, so we can give them steroids. And you all know about steroids and teaching that are appropriate. And we can use IVIG that will help bind to the receptors in the macrophages that are eating up all the platelets. High doses are required, and it is very expensive, so we may not see it a lot. And then there is a medication, the trade name is called Amicor, that can destroy the production, and you could see that. So let's talk a little bit about nursing care. I'll give you a pretty good list. We do need to do an adequate health history, medication, um, recent viral illnesses that could contribute to this, do a physical assessment looking for petechiae, purpura, ecchymosis, bleeding, neuro assessment, certainly looking for things like headache, vision disturbances, balance, and confusion. Those can be the first signs of bleeding into the brain. We all know what bleeding precautions are and how to protect them. We need to avoid venipunctures, IM, sub-Q injections. If we have to do that, we've got to hold pressure on those for 10 minutes. We want to avoid things like rectal temperature, suppositories, even automatic blood pressure cuffs, which we use all the time in the ICU, because they do squeeze rather tight and can stay on the arm and hold a little bit of pressure. We need to do soft toothbrushes. We can use the soft oral swabs in their mouths. Certainly, if they start to bleed, we've got to hold that for 10 minutes. We need to monitor for signs that tell us they're bleeding, like tachycardia, hypotension, altered mental status, tachypnea, and certainly report any bleeding or new symptoms to our healthcare provider. We're going to monitor our labs, look at our platelets. Certainly if they're bleeding, we want to look at H&H. We can look at coax studies, but for most of these coax studies are not abnormal vital signs and any hemodynamic changes. Not a lot on lifestyle for these. Primary ITP can occur more in children and more in women. The elderly are not going to do as well, but if you have a pregnant client that has thrombocytopenia, it's not really common, but they cannot, if they come for delivery, they can't have a spinal, they cannot have an epidural, they will have to have general anesthesia if they have a C-section. And certainly we want to minimize blood loss, which kind of depends on lots of factors, whether they have a vag delivery or a C-section. So we certainly want to educate our patients on the disease, exacerbations of the disease, when to call the healthcare provider, when they have bleeding that becomes uncontrolled or new bruises or purpurus coming up. No contact sports. Don't eat plenty of whole grains so that you're not constipated. Don't strain. Over-the-counter medications. So we don't need them to use aspirin or NSAIDs. Anything that may lead to bleeding. You certainly need to ask about herbs and supplements that they take, because some of those do cause bleeding. If they have a nosebleed, they need to sit down, lean forward, and pinch the nostrils or up at the bridge of the nose so that they're not swallowing all that blood. And if they can't get that under control, they will need to come in, and we will actually put, they actually do call them a nasal tampon. They can either pack it or actually put like a tampon-like device and blow up that will stay there for a couple of days. If the ED puts that in, then they're going to have to come back to the ED to have that removed. Certainly if they've got blood in their urine stool, they need to come in and see us for those, and just safety and precautions to decrease their injury and bleeding. So if the patient is not very active, they will tolerate a fairly low platelet count without any problems. If they're more active, we will need to worry about them. And outside of doing things that are just dangerous or contact sports, they can get out and walk and they can do things. They just need to be very cautious with their making sure they're not getting injured. Okay, so we're going to talk about heparin-induced thrombocytopenia, or HIT. And what happens with this is people who are on heparin. It does occur more if they are on unfractionated heparin, which is what we use IV, versus fractionated or low molecular weight heparin, but any kind of heparin can cause this. It usually occurs between 5 to 10 days after the start of heparin, but it can occur earlier or later, and this is life-threatening. I have seen this a couple of times. And what happens is their body forms antibodies against this heparin platelet complex that stimulates the removal of the complex by macrophages, which leads to thrombocytopenia. So these patients are not going to bleed. Their problem is they are making clots. And the way to remember that is we're giving them heparin because they have clots. We need the clots to go away. We're not giving them heparin, which means they're going to clot, which also means that if we are following their PTT or APTT, those values will actually start to fall because they are not thin, which is our goal for heparin, or we're having to increase that. Now, the criteria is we suspect this if their platelet count falls by more than 50% from the highest count after heparin was started. So we need to look back, see what that platelet count was, and if it falls by 50%, we need to suspect this. This is caused by all types and routes of heparin, even sub-Q. So our treatments are pretty simple. We're going to stop the heparin. And we need to find heparin wherever it's at. If they have a heparin-coated central line, we need to get that out of them. We don't do heparin flushes. We wouldn't want it in our pressure bags. We don't want it IV. We don't want it sub-Q. We do have to start additional anticoagulation because they are thrombotic and are making clots and will die from clots. There is a test. It's a HIT antibody test. It's got some fancy names. I've always heard it called the HIT antibody test, so that's what we're going to go with. So there's several additional anticoagulations that we can start them on. Agathroban, apixaban could actually be used. Warfarin, low molecular weight heparin, and platelets should all be avoided because the platelets are going to get bound up in those antibodies and it's not going to work and can lead to more clots. So what we're going to do for them, number one, you need to be aware that they will have to continue anticoagulation for 3 to 6 months. And they absolutely cannot ever have heparin again. I would consider that an allergy and that they need to list that as their allergy and say that they have a severe reaction to it. I've seen patients survive, and I've also heard of patients who have died from this. So stopping heparin is what really does it, and monitoring them for thrombosis. And the place they're going to clot is, it can be venous, it can be arterial, it can be both. They can get a clot in their leg that leads to arterial ischemia where that leg has to be amputated. They can get clots in their heart. They're going to have an MI. They can have a clot in their brain, which is going to lead to a stroke. They can have a PE. All of those things. We could do plasmapheresis for severe clotting to remove those antibodies. I've not seen that happen, but that is something that could happen for them to treat their HIT. Okay, so we are at the end of our slides. This is kind of a few minutes over my kind of standard. I tried to keep it about 15 minutes, but I knew we could get through this. So think of what you already know. You've really learned about this. This is keeping these patients safe, and you learned a lot about that just in previous semesters with cancer and all those type of things. So this is really important for monitoring and lots of patient education. Thank you so much.